So today I'll be discussing about general things in the ICU, and in this general topic I'll be discussing about four things. The first one is the critical care scoring system. Second is shock, a general overview of the shock. Third, we will discuss about the basic hemodynamic monitoring. I'm not going into the advanced hemodynamic monitoring. And the fourth one, we will discuss about lactic acidosis. Let's first see the critical care scoring systems. Now, they are developed to evaluate delivery of care to the patient and to provide prediction of outcome of critically ill patient. These system consist of two parts. The first is the severity score, which is a number. The higher the number is, the more severe the patient's condition, and a calculated probability of mortality. So how do we classify these scoring systems? These are classified on the basis of anatomical scores, which depend on the anatomical area involved, such as abbreviated injury score and injury severity score. Then we have the therapeutic weighted scores. These scores are based on the assumption that very ill patient will require more complex interventions and procedures than patients who are not that sick. Example include therapeutic intervention scoring system, the TISS. Then there are organ-specific systems which are similar to the therapeutic scoring. The sicker a patient is, the more organ systems will be involved. And the example is sequential organ failure assessment, that is the SOFA score. Now, there are certain scoring systems which are based on the physiological assessment, that is based on the degree of derangement of the routinely measured physiological measures, such as the acute physiology and chronic health evaluation, the Apache score, and the simplified acute physiology score, the SAP score. And there are certain disease-specific scores such as Ranson's criteria for acute pancreatitis, World Federation of Neurosurgeons score for subarachnoid hemorrhage, and Child-Cook or MLT score for liver failure assessment. Now, I'm not going into the disease-specific score because they will be discussed with the specific disease, and I'm also not discussing the anatomical score, which will be discussed with the trauma. So I'll be discussing about the general scoring systems which we use in the ICU patients. The first day scoring systems include Apache score, SAP score, and MPM, that is the mortality prediction model. The repetitive scoring systems which we can repeated you use in the patients when they are admitted in our ICU, and they include the organ system failure, the SOFA score, Odin score, and the multiple organ dysfunction score. So let's first see the Apache score. It is the best known and most widely used with good calibration and discrimination. The original Apache, that is the Apache 1, was developed in 1981 to classify groups of patients according to the severity of illness, and it was divided into two sections. The first one is the physiology score to assess the degree of acute illness, and pre-admission evaluation to determine the chronic health status. So first is the physiological score, which measures 34 physiological measures and are scored from 0 to 4. Then we measure the sum of all acute physiological score, and the worst of initial 24 hours after ICU admission is taken as the final score. Chronic health is graded from A to D, with A being the excellent health and D being the severe chronic organ system insufficiency. Now, Apache 2, which is the most commonly used score which we use commonly, it was released in 1985 and number of variables were reduced to 12. Earlier in Apache, there were 34 physiological measures. In Apache 2, there are 12 physiological measures. The Apache 2 score ranges from 0 to 71 and is measured during the first 24 hours of ICU admission with a maximum score of 71. Now, a score of 25 represents predicted mortality of 50%, and a score of over 35 represents predicted mortality of 80%. So, with the use of this score, we can see what is the predicted mortality in our patient. This score is sum of acute physiological score, which, as I have told you, consists of 12 variables, the age, and the chronic health score. There is an algorithm used to measure the final score. Now, what are the 12 physiological variables? Because this is usually asked in our multiple choice questions. The first one is the temperature. Second is MAP, that is the mean arterial pressure. Third is heart rate. Fourth is respiratory rate. Then oxygenation. Then arterial pH. These two value we get on ABG. Bicarb, which we get on ABG. Potassium, sodium, serum creatinine, hematocrit, TLC, and the GCS score. GCS score you all know how to calculate, and this is the age score. So we feed all these in a calculated model, and the algorithm gives us the final score. Now, Apache 3 was released in 1991 and has got 17 physiological variables, and the total score ranges from 0 to 299. It also includes the acid-base disturbances, age score, and 7 comorbidities. The Apache 4 scoring system came into limelight in 1996, and it has got 142 variables. This requires web-based calculations, and it is developed and validated only in ICUs of United States of America. These two, Apache 3 and Apache 4, are far more complex than the previous two scoring systems, and the most commonly we use is Apache 2 score. The next is the simplified acute physiological score, that is the SAPS. It was released in 1984 as an alternative to the Apache score. The original SAP score is obtained in the first 24 hours of ICU admission by assessment of 14 physiological variables. This number of physiological variables is very important in all the scores because this is usually asked in the MC questions. In the original SAP score, there was no input of pre-existing disease. This score was superseded by SAPS 2 and SAPS 3 score, both of which assess the 12 physiological variables in the first 24 hours of ICU admission, and these two include the weightings of pre-admission, health status, and age. The original SAPS, that is the SAPS 1, did not include the input of pre-existing disease. Now, what are the variables which we see in the SAPS 2 score? So both Apache 2 and SAPS 2 has got 12 variables. In these, the variables are heart rate, SBP, temperature, P/F ratio, urine output, serum urea, TLC count, potassium, sodium, bicarb, bilirubin, and GCS. As you can see that potassium, sodium, GCS, this is common in both the scores. Now, SAPS 3 is the only score which we collect within the first hour. Apache 2, SAPS 2. They are collected within the first 24 hours, but SAPS 3 is collected within first hour of entry to ICU. So it allows predicting outcome even before we do any intervention in our patient. Therefore, it is a better evaluation of an individual patient rather. So obviously it has got the limitations that for the time for collecting data is less, we have to do it in the first hour, and can have greater missing information because we are busy in planning our interventions and resuscitating our patient in the golden hour. Next is the sequential organ failure assessment, that is a SOFA score. This SOFA score is a repetitive score because we can repeatedly do it our patient. We can do it in every day, but the Apache score and the SAP score ideally should be done within the first 24 hours of ICU admission. This SOFA score was developed in 1994, and it was developed to describe degree of organ dysfunction associated with sepsis in a mixed medical surgical ICU patients. Remember that the patients were associated with sepsis, but now SOFA score is used for all our patients, both sepsis and non-sepsis patients, because now it has been validated to describe the degree of organ dysfunction in various ICU patient groups, even without sepsis. So, sepsis score involves 6 organ systems, that is respiratory, cardiovascular, renal, hepatic, central nervous, and coagulation. And the function of each is scored from 0 to 4, 0 being the normal function and 4 being the most abnormal function, giving a total possible score of 0 to 24. 6 organ systems multiplied by 4, the worst outcome will be 24. So, how do we assess this? The sequential organ failure assessment. What do this score tell us about the patient? The interpretation of this score. Mortality increases as the number of organ with dysfunction increases. So unlike other score, the worst value on each day is recorded. Not the first value, but the worst value on each day is recorded for SOFA score. There is a key difference in the cardiovascular component. Instead of the composite variable, that is what is the heart rate, what is the BP, the SOFA score uses treatment related variable, that is the amount of vasopressor required for maintaining normal BP, the dose of vasopressor agent. This is the difference in the cardiovascular component of SOFA and other scores. Now in respiration, we see the P/F ratio. In coagulation, we see the platelet count. To assess the liver, we see bilirubin. To assess the cardiovascular component, we see how much amount of vasopressor, dopamine or epinephrine or norepinephrine is required. To assess the central nervous system, we input the value of GCS. To evaluate the renal system, we measure creatinine and enter the urine output. So as you can see, with the worst variables, the score of each system becomes 4 and the total score can approach to 24 if there is multi-organ dysfunction. Let's go to second part of our general topic, that is shock. Now, shock is a physiological state characterized by significant systemic reduction in tissue perfusion, resulting in decreased tissue oxygen delivery and insufficient removal of cellular metabolic products, resulting in tissue injury. Now, it is usually defined by a combination of hemodynamic parameters such as mean arterial pressure less than 60 or systolic blood pressure less than 90. I'm sorry, it is written more than 90, it should be less than 90. Clinical findings such as altered mentation, decreased urine output, and abnormal lab values. That is elevated serum lactate more than 2 millimoles per liter or presence of metabolic acidosis.